Good afternoon, and this is it's an interactive, innovative retina session for. Would like to call upon our masters here. I would like to call Dr. Mahesh Shanmugam and Dr. Kim Ramasamy and Dr. Lalit Varma to be on chair, please. I would like to call upon all the innovators here to be in the front. Dr. Aditya, Dr. Sunil, Dr. Piyush, Dr. Somil, Dr. Shashank, Dr. Anirudh, Dr. Gopal, Dr. Vinod, and Dr. Unni. So, there's a little change in the sequence because Dr. Sunil has to catch a flight. So we will start with Dr. Sunil first. Yes, please. I have called said. So we'll start with Dr. Sunil. Yeah, Dr. Sunil, you can start it here.
Good afternoon, everyone. Basically, I'll be showing 3 short videos with some surgical modifications techniques. The first is a modification to finesse loop. You can use a 50 Prolin. Video is not running. And not the previous one. Go back. Yeah. I've got a pen drive if you want. You can plug it. It's not working. Upload किया था मैंने.
Just पहला वाला video.
Yeah, it's okay. Open the pen drive. Now it will. क्या कर रहा है? स्कैन कर रहा है. It was scanned only. I can.
So I would, though our masters are here, but again, I would request all the innovators also to put their inputs into this. So we should have an interactive discussion about how to go about it. Dr. Sunil, ready?
Yeah.
And we are doing this session for, this is the 7th year of consecutive year, and MPS sir was there since inception of this concept, and he was guiding us for each and every session. So we are really indebted to sir for this, and Kim sir also has joined us for the last few sessions as well. We'll have a 3 minutes short video so that we can start discussing about it. Okay. Dr. Aditya, do you have your video ready now? Yeah. So you have uploaded? You can come there.
So I'm going to talk to you about my experience of using an amniotic membrane graft in a recurrent optic disc pit maculopathy. She's a 9-year-old girl who had a recurrence of optic disc maculopathy, and she presented to us with schisis again. Can I start?
Yeah.
Okay. So the plan was to put the amniotic membrane graft.
We decided to operate the girl with 3 mm refined
So
human
the
amniotic
optic pit
membrane
which
graft.
we measured
Because of the larger
with the help
size
of the
optic
OCT was
disc
about
pit.
1.5 millimeters in size. So we opted to choose a graft size of 3 millimeters so as to make sure that the optic disc pit is completely occupied by the amniotic membrane graft. So we stained the graft using the brilliant blue. You can see the previous ILM peeling has been done and there is a small flap of ILM over the macular area, foveal area.
After trephination, the graft was stained with
So the
brilliant
way
blue.
to grasp this amniotic membrane graft is to ensure
With
that the
help of
tip does not
intraarticular
have the graft in
forceps,
front,
the
in fact it
graft
has
was
it at the back.
directed into the eye
And I don't really
onto
need
the
to
optic
stuff
disc.
this amniotic membrane
The
graft
visual
into the pit.
feedback
I'm not
offered
pressing it
by
as
the
much as I showed in the
intraoperative
video,
OCT and the
but it
larger size
automatically
of the
gets
graft
captured into that
was
optic pit
helpful
due to
in
the negative
ensuring a
suction
snug fit
forces.
of the patched
The
graft into
intraoperative
the optic
OCT
disc
confirms
pit.
the optic pit is fully covered by the amniotic membrane graft. And with that, there is no need for any
This
additional laser or
obviated the
additional
need for
tamponade being used.
any additional tamponade
So all
or
that we
laser
ensured is that the graft
or
is in
any
place.
TFCL for stabilization of the graft or any additional maneuvers to ensure the stabilization of the graft. To our surprise,
So within
we
48
observed
hours, you
dramatic
can see there is a
resolution
dramatic
of
resolution of the
maculopathy
chysis
and retinoschisis
and with no
within
additional
48
tamponade or
hours.
laser.
And the best corrected visual acuity improved to 6/80. Along with using a larger graft, which was easy to
So we
maneuver,
ensured that there is a snug fit of the graft into the optic pit, and that's probably how it helped us in resolving this maculopathy without any additional tamponade.
Yeah. Thank you, Dr. Aditya. Now, the question it's just a general question to all of us. Let us discuss what is actually the fate of amniotic membrane down the course. So, what does it get absorbed completely, or it remains like that? So that the permanent, because this is an optic, this is a tissue deficiency is here. So if something which is gets absorbed over a period of time may not be the good idea to put into it. Sir, I know that MPS sir, you have put sclera also. So now the question for you, the sclera is not as pliable like amniotic membrane. So if there is any gap remains in the sclera, like how he has folded it into and properly stuffed it there. So do you think sclera versus amniotic membrane, your opinion? Versus ILM as well. This is an universal plugging method versus anterior capsule. So just an your
Earlier, macular hole was the dustbin. Now the optic pit is the dustbin. So you put anything and everything into the optic now. Correct. Yeah, that's right. Yes. So I don't think you need to have a watertight closure of something inside the optic disc pit for it to close. It's not like that actually. So something which is tough fit, and most importantly, we still don't know what works. Just a PVD induction has probably worked. ILM peeling people have not done also. It has worked. I think there are two bunches of patients as far as optic disc pit is concerned. One of them has that CSF which is coming out into the vitreous cavity through the optic disc pit. So those probably are the ones which need a stuffing. The ones where there is no communication to the CSF, I strongly believe that both are there. CSF, there is one bunch which has a CSF also component, the other one which doesn't have a CSF component. The one which doesn't have a CSF component are the ones where probably you just do a vitrectomy without doing anything is also going to work. So you don't need a watertight stuffing that goes inside. And sclera also, though it's not pliable, it's not as though like it has to completely close the plug. Some amount of inflammation also happens, so probably it goes
Takes
away
care
is
of
what I
that.
would think.
Yes, sir.
No, it does. Does it go away? It doesn't. Not the sclera definitely doesn't go away, and amniotic membrane.
Also
I don't
doesn't go
have
away.
an.
No.
Does
Doesn't
it,
go away.
Do you see it going away? Yeah, it
I
doesn't.
remember like what happens is Dr. Samira Naik in the morning also we were discussing. She was the one who started using amniotic for macular holes many years back, and then like it stays for months or years together, and after that it slowly gets absorbed.
No, do you have evidence that it is?
Yes, she has that. Like I think like it become smaller, And then I think who showed in the morning also, they put for the macular hole and then getting integrated into the retina, and then you can't make out the amniotic membrane.
That is the only thing. Yeah.
Hello, hello. Hanji, good morning. I am Dr. Rajpal. Good afternoon.
Yes, sir.
And for the last 5 years, I am following optic disc maculopathy. So I once we don't know which case which will work, but stuffing is also the object. In one case, stuffing increase the resolution. Resolution is faster. We have a 3-4 case where the scler stuff is done. Resolution is faster. We have only done simple PVD induction. The resolution takes time. And another I would like to say, do surgery early. People are very reluctant to do surgery, and we have done a surgery in a 6/9 case, and today after 9 months the patient retina is flat, everything has 6/6 vision is attained. So it is better to operate early because of the improvement in surgical technique. Thank you.
Sir, there is a one question is whether early or a good vision. So these two is.
No, the thing is, I will say early, because earlier you do, resolution is faster, correction of vision is all right. We have a 20 documented cases of like this. So earlier I was afraid, because when I have operated case of 6/18 or, well, it is ideally it is said you should operate at the 6/18 vision, because it's difficult. People say 6/18, 6/12, but in 6/18 vision, sometime we are unable to get 6/6. Understand?
True.
But 6/6 18 vision you can get a 6/12. No complete data is available. I have a first-hand information of the 20 cases which I am following for the last 5 years.
I value your data, but believe me, I do not have guts to go inside a 6/9 or 6/6 with PIT.
No, 6/9 vision, just
6/9,
PVD.
yeah.
No, that is why I am telling you the 2-3
You see,
cases
because
experience.
natural course is not so bad that there are a lot of patients who maintain 6/9 for years and years.
No, yes, I have seen this
So-
case for the 5 years, from 13 onwards. I am just following that case. It's gradual. You know, it takes 5 years becoming from 6/6 to 6/6. It takes 5 years gradually few. So it is very difficult. I understand. It is very difficult. Complication is very high. But that is the thing. I am not saying you should operate early. But the thing is, 1 or 2 cases where we have operated early, there is a complete resolution. But that is, thank you.
Does anybody believe in still doing a laser for this patient?
That was the next question.
I believe, sir. I believe, yes.
Yes,
You-
Dr.
you
Pradeep, Dr. Pradeep Venkatesh, Dr. Lalit has done 3-4 cases, and they have documented initially, and they have a good resolution of these.
I
That is
have
the-
a follow-up of very long time where, we had done papillomacular bundle laser, and at that time, I know for whatever reason, at that time I never
We
understood
didn't
pathology.
think of that at that
I
time.
never
Yeah, we
thought-
were doing only lasers earlier.
Now to MP sir, so if you believe for the laser also works, so would you try laser, or what is your opinion, laser versus?
No, it depends on, like, you have to do the OCT close to the optic nerve head and the peripapillary region, and you will find that gap. So where there is a communication, and if the gap is very narrow, I don't have a number for it, it's very narrow, then the inflammation induced by the laser is able to close it, and then it seals it. It doesn't have to extend. So if that gap is quite wide and there's a lot of schisis and a lot of fluid, then it may not work, in which case a vitrectomy is to be done. So it's usually the younger patients, like 8 years old, 9 years old, where you find a papillomacular bundle detachment or just about in all the fovea, and you find this space to be narrow, then you can do laser.
What would actually prevent the further fluid from going into the schisis area? Whereas the resolution of the schisis has to be on its own. And
Yeah.
usually we all see about maybe 6 months, 9 months resolution. But why is it that in some cases, like Dr. Rajpal was also telling, within 48 hours will there be an improvement based on the fluid?
I don't think so.
Not 48
I don't
hours.
think so it
takes
happens.
3-4. I mean, resolution with the scler plug, I don't know that is the cause, but resolution was within 1 month or 2 months. The decrease, I am not complete resolution, but decrease in the height of the NST was 1 to 2 months as compared to if you do just.
The reason for
Just-
the
just a last
spontaneous
que-
closure
oh,
in our case was probably because the eye was already vitrectomized. So the subretinal fluid was quite liquid, more than actual
We will remain
SRF.
in the pit if we continue with the discussion of the pit.
we know that. This is last question to you, sir. How to differentiate whether CSF is working, CSF is there also,
That's
or
very
this
difficult
is?
to make out. The one case I am talking about was when I was operating, I could figure out. So it was a small child where I opened up and then, like, stuffed is sclera, a nice amount of sclera. You could see actually the sclera being pushed out. you could literally see it.
On die and whether it is coming to that.
Yeah,
Okay.
Good
You
idea.
can do it
This
in
is- this
Amrita,
is-
but I cannot do it in Shankaraya Hospital. So I stuffed it inside, it came out. Then I put 2 bits of sclera inside, and then both were also popping out. So ultimately I put it in and then put fibrin glue and left it like that. So that's how I know that like CSF does have a role to play. I have a video also, but of course I don't have my laptop here.
Yes,
doesn't
off the
the
record, I have taken out that thing and sent. It was a protein CSF. 10 years back, I have documented.
Don't
It
you
is a
have a
CSF.
good OCT? You'll be able to track that?
Yeah, you
The
may be able
country-
to sort of, but the depth of the communication is the what I'm saying.
Time to come out of the
yeah.
pit, I think.
Yeah, I think Sunil is also will show a different method of handling the pit. Sunil.
Okay.
No, he
The
has
first,
3
let
videos.
me show a case of a how to a 50 polypropylene suture, how it can be used as a loop, can be used as a membrane scraper. It threaded into a 23 gauge needle, the 50 polypropylene suture. Create a serrations on the loop of the suture, so it gives a grip for the whatever the peeling method you do. The case of a regmentogenesis retinal detachment with a triamcinolone assisted PVD induction, it works as good as the finesse loop.
So I will peel the ILM with this.
No, sir, it's a hyaloid which we have kept.
Yeah. This what you can use is you have this Lasix sponge.
Okay, sir.
So you can cut a tip of it and then use that also. That we
Okay.
have also published also.
Okay.
So that also you can use. So
Yeah,
that's
this-
because this doesn't work for the ILM.
Yes.
I in fact tried using creating the same thing with the stainless steel stillet which comes in
Okay,
the needle.
okay.
But something about the finesse loop has the serrations are much more like
Prominent.
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 Here, whatever you do, you're not able to peel the ILM.
Yes.
So the other instrument you can use is you take the Lasix sponge, cut a small bit of it, and that also works. And the thing about Lasix sponges, you can eat it off with a cutter. At the end of once it works, the work is over, then you can eat it off with a cutter. That's another thing you can use.
But it may get dislodged during that surgery.
Which one? No, you hold it to the forceps. Sir. You hold it to the forceps and wipe it. And once you wipe it and then like the work is done, the posterior hyaloid is removed, then you can eat it off with a cutter.
The second one is we are talking about the optic disc pit. This is a pit with a chronic foveoschisis with an intraretinal fluid. The schisis takes long time as we know, so we can directly aspirate the intraretinal schitic fluid with a 41 gauge cannula. This is the technique which I am showing there. This is a long standing schisis. So you can choose a multiple quadrants for the aspiration. It's a triamcinolone assisted vitrectomy being done. As we told, it may take months together for some of the fluid to get resolved. So probably active aspiration sometimes will allow us for an early resolution and getting an anatomical restoration in these schitic cavities. So it's a chronic schitic cavity. So we go with a 41 gauge cannula. Aspirate the residual triamcinolone precipitates and go in with a 41 gauge cannula. But I don't have an access to intra-op OCT to exactly see where exactly I am aspirating the fluid. It's a little bit blind maneuver.
Difficult to predict.
But you can see the color of the thing. It's a very chronic schitic cavity. So you can do it and probably you may get an early anatomical restoration. This is one of the modifications which you can do in a cases of a chronic schitic cavity if you have got in a case of an optic disc pit. These are self-sealing entry wounds, so safer, you can easily do that. And do a fluid air exchange. And
See that.
the next modification probably I would let, you want to discuss this, sir?
No, next.
Next, okay. Yeah,
Best is that you don't go into the pit again.
correct, sir. So next modification is a case of a PCV with a subretinal and sub-RP hemorrhage. Here I used a fluorescein stained tissue plasminogen activator into the subretinal space. The advantages of it is it stains the entry sites. You can know exactly where it is reflection is coming on, and it is connected to the viscous fluid injection site. So it will be a very controlled injection site. So the chances of iatrogenic macular hole and other things will be less. Then once you have done that, do a fluid air exchange, and you can wait for the resolution of the fluid. Resolution of hemorrhage rather. Regarding the toxicity issue, these are the 3 cases of microperimetry we did it. There is not much evidence of retinal toxicity. I don't have an access to ERG to say that the toxicity exists with this technique. Thank you for your patient hearing.
Yes, definitely some innovative thoughts. I think first, sir has already described about that. Any opinion regarding the second one, sir? Because
Sometimes I inject along with that BBG, because the aim is to see that whether you are in the right plane or not. Some people have used air also along with it, and fluorescein also I have seen. But I don't think so it makes any difference from the point of view of movement of the hemorrhage, because aim is to
It won't
display-
help, sir. The only thing is which site to choose. Suppose there is a re-entry is easily possible through because it stains the edges. You can go through the same puncture site again. The other thing
But I
is
actually don't want to go through the same side.
possibly if you someone planning to go through, and you can. And other thing is
Normally we plan to have 2-3 areas.
Yeah.
You see 2-3 mounts, because it's not never a single mount like you have. Normally you have big
and
mounts
another thing, it
everywhere.
gives a clue to which are the areas to avoid, sir, rather to where you should stop injecting the thing.
There was one publication from RP Center also to use air along with the yeah, a cocktail, yeah. So we use mocktail instead of cocktail.
This case actually you could manage with just intravitreal TPA and gas, because vitreous cavity is clear, you can see it, and the fluid, the hemorrhage at the fovea was not very dense as well,
In
and
this case,
subretinal
yes.
hemorrhage,
In
not
this case,
sub-RP. So in this patient, if you ask me, I would have injected TPA and intravitreal gas in
Intravitreal.
prone position,
Okay,
and the studies have shown the results to be the same as doing a vitrectomy.
okay. We'll move on to our next
Thank you.
speaker, Dr. Vinod.
Thank you. Good afternoon for having me here. So I'll be talking little of the macula. So this is a case, elderly male who presented to us with perforated corneal ulcer and lens extrusion. And he underwent therapeutic PK in March 27, and then patient was lost to follow-up. And subsequently, 1.5 years later, he presented with diminution of vision for many months. And when we saw him, basically he had a graft, failed graft, and a retinal detachment which was there on the ultrasound. And anterior segment and posterior segment retinal details were not visible. Now, once you have a patient with cornea hazy, you have various options, including first PK followed by a vitreoretinal surgery, or you can do a temporary K-Pro assisted VR surgery, and on the same sitting you can do a clear graft later on once your retina is attached, or you can do an endoscopic assisted vitreoretinal surgery. So I had this idea whereby we thought we could do something different. So this is a patient when he presented to us, and when we saw this patient, it was predominantly corneal edema and not scarring so much as per se. So what we did is we planned to do a conventional 3 ports vitrectomy, and after making the ports, I entered the eye, and you can see pupil is very small, and we could hardly see any retinal details. So what we did is scrape the cornea and then put glycerin. So it is a sterile glycerin which is there available with our eye bank. So we put that, and we thought it will clear up, but it did not. And then we realized that we have to be in contact with cornea with glycerin for some time for it to clear up. So what we did is we took some time and also replaced the viscoelastic in my contact lens with glycerin. So now after 2-3 attempts, slowly the cornea began to clear. And this time when we went in, I could see something. Of course, this video may not be that good because cornea is hazy, but we can see some retinal details, and there was some amount of vitreous hemorrhage. So I started my vitrectomy, and to my surprise, in few more minutes, I could see the retinal details. So as you can see here, you can see the retina now. The vitreous hemorrhage is there. Vitreous hemorrhage has been cleared. There is peripheral vitreous hemorrhage, which is I'm doing near the peripheral retina. Now you can see the disc, and also you can see a subretinal band which is running along the infratemporal arcade. So fairly good corneal clarity was achieved by now, and I made a retinotomy along the infratemporal arcade. In fact, the clarity was enough for me to do a subretinal band removal. And once the subretinal band removal was done, I used this break for fluid air exchange and subsequent completion of vitrectomy, and I completed my surgery. So so this is how the cornea looks like at the end of the surgery. So you can see the cornea has fairly cleared up, and it allowed me all the maneuvers we required to do in a patient with retinal detachment. So this was subsequent cases, again a very bad cornea, a PK with retinal detachment. Here also you can see the cornea was quite bad, but subsequently at the end of the surgery you can see the cornea has cleared up. It gives you a good evaluation of the posterior pole during the surgery, and you can do your surgery in a normal way, and subsequently once the retina is attached, you can take up the patient for corneal graft in a more controlled way. So you can see here, this is the second patient. On your right side is cornea before surgery, and this is at the end of the surgery, which has fairly cleared up. So this is other cases. On your left side, you can see this is a patient who had a desect lenticule which has gone inside the vitreous cavity. Again, because the cornea was just edematous and not scarred, with glycerin I could complete the surgery. And this on my right side is the fourth case. Again, you can see that the cornea cleared up nicely, and in this case I could do even ILM peeling easily. So what are the advantages of this technique? It acts within minutes. It allows us enough clarity of media to perform various posterior segment maneuvers. It prevents any delays in treatment because of availability of cornea and temporary capros. Endoscopy may not be available always. It's a cost-effective treatment because glycerin is quite cheap, but the only caveat is that you need to have not predominant scarring. Once the predominant scarring is there, this technique is not going to work. In fact, we published this series in edematous in retina as a surgical technique. Thank you.
Yeah. Thanks a lot. I mean, this is really a newer way of looking into it. Combining with air in the AC, do you think that makes it a little more faster of the resolution of the corneal edema?
It may, but the initial part is because initially it may appear frustrating, but usually in most of the times I was doing air fluid exchange as per the requirement of the posterior segment and not for clearing of the cornea. Like as per protocol of posterior segment, when the air fluid exchange was indicated, at that time only did, not to clear the cornea.
Like we know this is a case where the graft had failed, right?
Yes, sir.
So what after the surgery, what do you do for the? Anyway, the graft has to be replaced.
Yes, sir. It's just that because cornea sometimes may not be available, K-Pro may not be available, and we have to call a corneal surgeon. So the thing is, once the cornea clears, you can complete your surgery in a normal way. Through temporary K-Pro, you can't look at the periphery of the retina very well. So that is not an issue with it. So once cornea is, you have done your surgery, you can always assess. And later on, if the retina is attached, you can combine the later SOR or subsequent procedures with the corneal grafts. It's much more controlled. And also the chances of graft failure decrease, because once you do a graft during the primary surgery, subsequently
that
further maneuvers will increase the chances of failure.
No, I agree. It's a very good. I have not done it, but seeing this result is more tempting. Whatsoever we have done is a temporary K-Pro, and but I was skeptical whether we can do a very fine job with this or not. You said ILM peeling also has been done. I think if there is no scarring, it should.
Yes, a little bit of scarring you can do away with, but if it is predominant scarring, that does not go, of course. But once you scrape off the epithelium, it's a very nice technique. Glycerin is very cheap. You can just make it sterile, put it on the cornea, and it just does the job.
At least you can try this technique before going for the K-Pro. Or
I think we get a fair bit of idea with pre-operative examination as to what kind of cornea we have.
Yeah, we do have this always in the OT, and we do use it. Like even at like microcystic edema during surgery, also you can put a drop, wait for a minute, and then it will go away, and then wash off the glycerin and go ahead to the surgery. One other additional step you can do is to use a dry cotton bud, roll it with a little bit of pressure on the cornea. That will also detergest the cornea a little bit faster. That can be done. Superficial edema, microcystic edema, but this can be used for some amount of stromal edema. It can be used. And putting in air from inside, that it becomes a little bit of an issue because the DM folds will happen because you don't want anything happening on the endothelial side to muck it up. So I would do things on the surface rather than from inside.
This will help only for the stromal edema or the epithelial edema. Not
It helps for both, sir, because epithelial.
Yeah, only for those two, not for the endothelial changes.
Sir, it will temporarily clear off. Temporarily, it will clear off everything. In fact, the clarity becomes very good, and you can do all your posterior segment procedures very comfortably. The periphery is much better visible.
No, it's eye bank glycerin.
Yes, sir.
So it is sterile.
Yes, sir.
No, because not many people are there. People should not use the commercially available glycerin on the table and end up in endophthalmitis.
No, this is the eye bank glycerin. Yes, sir. Yeah.
Yeah, we have actually sterilized and kept it aside. So glycerin is there in the theatre, sterile glycerin, which is what we use.
Yes. And it can be ETOs, or how do you use that, Dr. Vinod?
Sir, the eye bank people have it. We have it all the time.
But none of us is having the eye bank. So how we will use?
So I will have to find out that. I will get back to you on that.
Okay.
I can share.
Okay. Dr. Somil.
I can find out that and post in our group.
Yeah, ETO is the best way. Yeah, I think you can put into the group.
Definitely.
Dr. Somil. I'd thank Dr. Somil because Dr. Piyush was supposed to be here, but again, because of his leg fracture, Dr. Somil has took up and came out. Thank you. Thank you so much. It's short notice.
Thank you, Dr. Rupak, for allowing me to present this conceptual case actually. So this is about a subfoveal hard exudate plaque, and this subfoveal hard exudate plaque, as you see on the OCT, it is not under the neurosensory retina, it is intraretinal. It is intraretinal, it is not under the neurosensory retina. So the approach to this, normally what people do is they go under the fovea, they induce a saline induce neurosensory detachment, they disturb a lot of neural elements on the way to approach that plaque. When the plaque is intraretinal, all you need to do is don't disturb any of the neural elements, and rather than going from below, you would rather go from the top and create an iatrogenic macular hole, which I believe would be a lamellar hole, and it does not disturb any neural elements because all the neural elements are below that in the outer nuclear and the photoreceptor layer, and this will cause the least amount of damage. So it is a very counterintuitive concept. You are actually hitting the eye where you feel it is going to hurt the most, and it is where actually it will hurt the least. So you create an iatrogenic macular hole. This is the video for it. It's a 1-minute video, I guess. So this is post Ozurdex, and the edema is completely cleared of the retina. You can see there is some PDR here because there are some NVs that have got plucked off when the PVD was getting induced. So in this case, I first peel the ILM and then approach the plaque. In the second case, I did exactly the reverse because I thought that if I remove the plaque first and then do the ILM peeling, I can actually create an inverted flap and stuff it into the iatrogenic macular hole and expect that it would close like how a normal macular hole would. So wouldn't stuff it, let's say, just put it over there. So in this case, I first peel the ILM because I thought the approach to the hard exudate plaque will be easier. And I tried first with active suction, and it came off very easily. I assume that a little bit of neural elements would have come along with it, but cannot be sure unless you have an intraoperative OCT. And if you see the post-operative OCT, the hard exudates are practically gone. The visual acuity did improve. This was a case of severe diabetic retinopathy with subretinal as well as intraretinal hard exudate. You see a plaque over here. So the same procedure was followed. The only purpose of showing this video is that in this case, I went for the hard exudate plaque first, and instead of using an active suction, I actually took it off. You see the iatrogenic macular hole created much smaller than the size of the actual hard exudate plaque. And then after sucking off the plaque, staining the ILM, I just peeled it off, and in this case, actually flapped the ILM and put it onto the hole, and the hole closed like how a normal macular hole would with an inverted ILM flap. Thank you so much.
Yeah, this is innovative way. Sir, I think you had done few number of hard exudate removal earlier also. So the location, did you have the preoperative?
Yes, it has to be intraretinal. If it's subretinal, then it is better to approach it from the subneurosensory side by inducing a detachment. Only if it is intraretinal, the only place for intraretinal hard exudate plaque, I believe, is the plexiform layer.
Okay.
Or just below the Muller cell cap. All the neural elements are below that. So to approach it from below would be damaging all the neural elements while getting to the plaque. So it will not cause any, it will cause collateral damage while removing the plaque.
Okay. Sir.
See, I didn't want to comment. He asked me to comment. Shamil doesn't want me to talk actually. Anyway.
No, I do.
No, this is a very old, many years ago we used to do that, but then the visual results are not commensurate with what we do surgically. That's the reason it was given up, and then subsequently pharmacological or non-pharmacological methods are used, for trying to control the lipid level, then intravitreal steroids, anti-VEGFs, all those things do bring down the hard exudates also. What happens is, all said and done, there is some amount of retinal atrophy in the area of the hard exudates. So even after it goes away or physically you remove it, the visual results are not great. As you said, the first patient was count fingers 3 meters to 636. Second patient, I don't know what are the results. So that's a problem.
So I've done 5 to 6 cases, only one has improved, frankly.
That's he himself has
yes.
given the reason. That's the reason probably we don't do it.
More it is a subretinal, the chance of visual recovery is less. So if it is intraretinal,
it depends on the amount of extent of retinal
actually is a little bit easier, because I think there are techniques where you induce a macular detachment and then put a gas and then ask the patient to maintain prone, it goes away. But it's not as simple, because sometimes it's a fresh hard exudate moves, but otherwise it doesn't move. So there is already RP atrophy and there are already intraretinal damage. So the visual results are not commensurate with the amount of surgery you do. And at the end of it, there's always a possibility of retinal detachment with a vitrectomy. That's right.
So what he said is that the visual results are not commensurate with the surgical technique, but at least in all the 6 cases, there was no decline in vision. At least it was stable. So at least do no harm is what I thought probably would be the take home. Yes, they do.
Yeah. So we need to have a head-on trial for that. So next time.
You can't have a trial because ethical issues will come. With the pharmacological treatment being available, so that's the issue. Right?
Dr. Vishal.
Thank you. Thank you, Dr. Rupakanti Vishwas, for having me here. I'll be, speaking about the management of submacular hemorrhage by a simple homemade device. So, and that is not just useful in submacular hemorrhage; it's also useful in, aspiration of subretinal retained PFO. So this was, a case of 64-year-old male, left eye, a sudden decrease in vision, with hand movement close to face and a massive submacular bleed of more than 10 disc diameters. And this is the fundus photograph, and the hemorrhage is extending beyond the arcade, and this is the OCT, and the plan was PPV plus subretinal TPA. So we started the PPV, and this was the first case we did. So this is the representative case here. And a gentle PVD induction was done, and it was not coming off with the cutter suction, so we used a little bit of help from the forceps and made a small opening in the hyaloid and just lifted it with the help of forceps and a mild section from the cutter. So now the vitrectomy is complete, and now comes the important step of subretinal drug delivery. And we all know that we are using 41 gauge cannulas, whether we are injecting it or whether the assistant is injecting, and it is a non-calibrated, and there are multiple devices available in the market also. But the VFC injection system is non-calibrated. You can have fine tremors at the edge, at the tip of the 41 gauge cannula. So we tried to modify it, and with the simple VFC kit available, in the OT. So this is a foot switch operated injector aspiration system. So you remove the piston, you remove the black piston from it, you cut the VFC tubing from the edge. This is a reused VFC. You inject, re-inject that seal, the black seal, into the shaft of the 1 ml syringe. Stuff it inside, and then connect that cut edge of the VFC tube to the shaft of the 1 ml syringe. And that actually fits very snugly, and it does not come out while aspirating and injecting. And now you can have your, self homemade injector aspiration system. So the injection is around 500 psi, and the aspiration is around 10 to 12 psi. And this works very fine, and it has a calibrated, drop by drop injection which comes out. And the second is already Dr. Sunil told, we just chained it with a drop of fluorescein. So while injecting into the subretinal space, it is visible. Now you can see after injecting, only a drop by drop injection system is there. So it is a certain gush of fluid does not go into the subretinal space and create a macular hole. So this was the macular hemorrhage, and we went inside with the 41 gauge cannula. And now we have pressed our foot switch, and you can see that bleb, the greenish hue, and the bleb, enlarging, and you can, stop where you want to, and the extent of the fluorescein dye going inside. And we've already discussed that there are no toxicity issues with that. Finally, you close with, anti-VEGF and gas. And some might argue that it is a subretinal hemorrhage, and it could have done well with the intravitreal TPA and anti-VEGF and prone positioning also. But to me, I think such a massive hemorrhage should be dealt in the subretinal space only. And these are the post-op photographs of the left eye. And this is a comparison of the OCT, pre-op OCT and the post-op OCT. And the fundus photographs of left eye and the post-operative fundus after 3 weeks. And just one more case, and this was done recently around 1 month back. And this is a much more massive submacular hemorrhage. And here also you can see that bleb being created, the greenish hue, the same technique used, the same injector system. And of course, there was a lot of scanning, but it worked in this case also. And it works wonderfully in retained subretinal PFO bubbles also. So foot controlled injector aspiration system is an excellent first choice instrument for access in subretinal space. Low cost, good calibration, and simple assembly are the advantages of this device. Thank you.
Any comment? No, this is definitely a innovative way of handling it, and but this is so well controlled. The main issue you have shown very clearly that there was a very controlled way of. That was the most important when you go to the subretinal space. Dr. Naresh, do you have any comment on this?
Yeah, he's been doing this actually, including the absorption of the PFCL bubble, subretinal PFCL bubble sometimes left behind. They're using same way of using a controlled way of aspirating this thing.
No, in fact, for submacular surgery, we use the same, but instead of filling the silicone oil, we fill the BSS with a 41 polyamide tip. We have got both metal and polyamide. I personally feel polyamide tip is better. Even for inducing, controlled inducing also, it's very good actually. But we use 5 ml also for that with BSS.
Okay, thanks, Dr. Vishal. Would like to see from Dr. Gopal.
Intraoperative choroidal detachment we all have seen. I had one video showing an intraoperative choroidal detachment developing, but I'm not showing it for interest of time. So this is about intraoperative choroidal detachment. One case came up like this. And you know that there is fluid, so we make a small opening a little more posterior and go inside. And I'm basically visualizing the movement of the, you can see the movement of the instrument below in the subretinal area, suprachoroidal area. And slowly with active suction, we are removing all the fluid. This is formed immediately, so it will easily come off. And you can see that the retina is almost completely flat now. And the idea is, there is some problem which led to a intraoperative choroidal detachment. Some fluid went inside the choroid. Maybe it was an oblique entry or thicker choroid than usual, inflamed choroid. Whatever reason, if this occurs, it may, you do not know how postoperatively it may behave. And at this point of time, you can do this opening and suck it off completely, and so that we have an attached retina by the end of surgery. Thank you.
Yeah. So, what is the chance of complication of
Yeah.
this aspiration?
Yeah, I've not done it many times. Most often in a retinal detachment case, if you have a choroidal detachment, we end up with silicone oil underfill, and by the next day, it is usually completely retinized settled.
Correct.
So I have done only in 2 or 3 cases. In 2 cases, it was successful. In 1 case, it developed some subretinal hemorrhage.
Yeah.
So in the periphery, it was in the periphery, so it did not came into the center, and I had to inadvertently use oil in that case, which I was not planning to use. So I stopped doing this technique. Just to show for
this
discussion.
serious choroidal detachment you're talking about.
Yeah.
So what if in case you just remove the trocar cannula and inject from the other side? So that itself, because like the trocar cannula kind of keeps the sclera and the kind of oppose. That's why the fluid doesn't come out.
That is a technique that we
in
use
20
now.
gauge surgery, we just used to leave it open, it'll come off. So like that, if you remove the trocar cannula and inject from that side, then the fluid may leak out.
No need to inject, sir. So currently what I do now is remove the trocar cannula and then do the surgery without the trocar cannula. And by the end of surgery, the choroidal detachment is vanished.
Then what is the question of this technique
Yeah,
now?
this was an earlier video I just showed, that's all. Okay.
I agree, but for the junior retina surgeons, so probably if you have a significant amount of the peripheral choroidal detachment, that is an indication that you can do that.
Maybe.
Yeah, so it should be a periphery and a significant amount of the.
Yeah, so that we do not injure any structure.
Correct. Correct. So, and you can do it by non-choroidal detachment area by including in just one cannula, the trocar, and before starting the surgery itself, you can do that.
No, but what sir said, no, that is the thing that I follow currently. You just remove the trocars and cannulas, and the whole choroidal, that area is connected to that, and you do the surgery without the trocar cannula. So by the end of surgery, with the pressure, with the mobility, with the vitreous coming out, slowly all this fluid will also have come out. Yeah, thanks.
The only thing is, all the companies stopped 6 mm cannula.
Yeah.
Is there any effort on our side to ask them to make 6 mm again? Because in case of choroidal detachment, it's very difficult. You have to drain. Sometimes the drainage is not complete. So to see the tip of a 4 mm cannula is very difficult.
We'll put that responsibility to you.
No,
you can ask.
6 mm 20 gauge steel cannula.
Yes, sir. That's the olden day. We have to switch.
I still use that.
All right. So,
I
but
use that. I have about 2, 3 or 4 of them, which is what I use. Like so, 20 gauge is what I use. Right.
But 23 and 26, they have completely stopped actually.
Correct. But like, I have never used a 23 gauge trocar cannula 6 mm. So I always use a steel one. So.
Regular needle, like what we did for ROP, just put a buckle and then use the regular needle, cut it to that size and use it in these cases.
Yeah.
We have done that.
Yes. Dr. Shashank.
Here. So I will be speaking on subretinal fluid injection in the management of large persistent macular holes. So I will be taking up those persistent holes in which the horizontal diameter is more than the vertical diameters. So I will present in couple of cases. In this case, this is a 65-year-old female with blurred vision from last 1 year with cataract and large macular hole, as you can see. We did a surgery with inverted ILM flap, which failed, and this was the status post first surgery. So we plan to do subretinal fluid in this case. This is how the technique is, which all of us be knowing. So we injected BSS, creating small blebs of fluid all around the macular hole, just to increase the pliability of the retina. Because in these kind of cases, it is stuck with RP and there is less scope of mobility with either the flap or the other techniques. So as it was the first case, we were not very sure about the result. So to top up, we just put a amniotic membrane over this. So what we did was, we did the SRA fluid all around the macular hole and then top it up with a amniotic graft over the macular hole. I didn't stuff it in, I just put it over the macular hole because graft is required only for like 2 to 3 days for the hole to close. So, sorry, this was the result 2 weeks down the line. These are the OCT scans, and this is the fundus photograph and the fundus autofluorescence of this case. You can see the amniotic membrane which is displaced and lying in the infratemporal part. Yes, this stays there for a long time and it integrates with the retina over a period of time. Surprisingly, in the autofluorescence, we show nothing at the area where the amniotic membrane is there. So this is how the final picture was. This is the second case, again the same thing, but it's a fresh case. It was not a case where the surgery was already done, but because of the configuration, we thought that it is better we give subretinal fluid in this. So this is again how the surgery was done, and again we combined it with the ILM flaps. So ILM flaps were created, and after creating the ILM flaps, we created small subretinal fluid injection and created the blebs to make the retina more pliable and emanating to closure. So this is the post-op picture in this case. These are the OCT pictures. As you can see, the hole is very well closed, and in both of these cases, the vision improved from 660 to 618. This is the third case which has been given by Abhishek Anand. Again, the configuration, you just note the configuration in which we are using this technique. This case, because it was his first case, he also combined it with the ILM flap, as you can see in the above OCT. And this hole closed and there was a gain in vision. So far I have done 5 cases. All have closed. I combined the first 2 with amniotic membrane and ILM flap, but as we gained more wisdom, next 3 were without flaps or AMG. BCVA recovered by 2 to 3 lines in all the cases, and there was no complications. There is this study, like Opestal study, in which they have used this technique in 41 cases, but they have not shown whether they have used for which configuration, whether the vertical height was more than the horizontal or vice versa. Thank you. Open for discussion.
Thank you, Dr. Shashank. MPS, sir.
I have personally not done this, so I would usually put something there. So either very large hole now, multiple failures, I would probably put a retinal graft. I have personally not done it. Of course, like there are reports of it making the retina a little loose and then pliable so that like it's able to close. Other one is you can massage the edges and make it closed. All that happens, but then I have not personally done it.
Yeah, just one important question. So now you have the large, most of them are type 1. So you have the closure of type 1. So there is an addition between at the margin of the hole.
Yes.
So now you are creating the bleb surrounding the hole.
Yes.
So and the RD is not connected to the hole.
So there is no RD.
No, the subretinal RD what you are creating.
Yes, we let the fluid come out of the hole.
Yes.
So that's why the flaps get raised and the retina becomes more pliable and then it comes closer to each other.
Yeah, I think Anirudh was here. So that was, we have our, in Calcutta meeting, we are just discussing. There are study which has described that you would create RD, but it should not come, the fluid should not come through the hole. So that's how.
What they have suggested is put a PFCL bubble over the macular hole and then induce the RD, and then when you are doing FG, then the apposition occurs better. That's the
This was shown in this Apostle study. They have done first few cases with that PFCL bubble over it, but after that they abandoned the technique and they did without the PFCL bubble.
That was our debate also, that this makes more sense that again, unless until the margin is not mobilized, it will not come closure.
They combined few cases with this massage also, but later on they abandoned the massage also. So they just injected the fluid and let it.
Okay. I think Dr. Naresh, you want to comment anything on this? Okay. So our next presenter, Dr. Anirudh, I think for next session we are a little late, but we got almost near 25 minutes later. So we'll try to give as early as possible. Please bear with us.
Thank you, Dr. Rupak, for the opportunity. Well, I will show 2 videos which are not innovations, but it is a little bit unconventional. First case, this was a case of a subretinal hemorrhage, and the presentation was pretty late. When this patient had come, you can see almost in the subfoveal, it's organized blood, and a part as the fresh bleeding was there. Generally in these cases, we give intravitreal, we don't go do a very intensive surgical procedure, but this patient was very keen to undergo the surgery to have a best of the results. So we tried in this case Because generally what we do, we give subretinal hemorrhage in subretinal TPA when the span of subretinal hemorrhage is within 2 weeks or so. So we give the subretinal TPA. As we can see, generally we try to give it away from the fovea and to avoid the macular hole, but the hemorrhage was in the posterior pole only. So this was a surgery we had given in 2 spots, the subretinal TPA. And if we see post-operative period, it actually responded. Within 3 weeks, there was slight improvement. Within 6 weeks, there was even better. But 3 months, the hemorrhage had gone totally. But now this macular hole had developed with a little bit of diminution of vision. But now we took this patient, did a macular hole surgery, an inverted flap technique. Here you can see now there is no subretinal hemorrhage at all. This is almost 3 months after the presentation. So doing this inverse flap technique in this macular hole, actually we had the proper closure, and to our surprise, there was improvement in vision as well. So it's in the old cases, it's worth trying this subretinal TPA as well. Sometimes it might work. Coming to the second case, this was a very high myopic macular hole. No instrument was reaching the posterior pole. We had done all the modification, changed the area of the trocar cannula, removed the cannula as well, but in spite of that, you can see after raising the flap also, I am unable to pick up the flap. So the only option which was left behind with the finesse loop, I know the video quality is not good because I could not focus it properly. Whenever we were introducing the instrument, it was getting defocused. But the intention was to remove the ILM as much as possible, and with the finesse loop itself, without using any instrument, because the instrument was not reaching, we could achieve the ILM pilling entirely, and actually this patient did pretty well. There was proper type 1 closure of the macular hole. So when we are in a trouble, we can use a finesse loop itself, which can give a good result. Thank you.
Yeah, it's a savior in both. So till how long, like he has shown organized him has gone out. So how long would you suggest, when should we do, till how many days? This was how many days?
This was or more than 1 month after the episode happened, the patient has presented. Generally, we do in 7 to 14 days, but
yeah, standard is within 2 weeks.
Within
but
2
again,
weeks.
Sir, but it doesn't look like a 1 month. It is even more than that, no? So much of
yeah,
organized.
that's the history given. The patient had given a history because a part of it was fresh as well. Like it didn't, it was not deglobalized.
So how much of?
No, it's a question. I don't know if the duration is as important because very often it is not reliable.
Yeah.
So we would still try if the patient is willing for it.
Both of us are lucky.
Yeah.
Okay. So so the take home is that yes, you can try it out even after so much of organized blood, and you can get away. So there is no chance of saying no to any other person. So we'll thank you, Dr.
Thank you.
Anil. We are running out of time. We request Dr. Unnikrishnan to present. Here? Okay. So he has 3 short videos of handling VMT cases of different ways.
I was just saying, I'm showing a very Ayurvedic vitreoretinal surgery, very simple cases about how to atraumatically remove the vitreous. Nothing very dramatic, but okay. So the usual thing is just pulling off, and that is not a great idea when you want when you have a critical attachment of the fovea. So 2 of these techniques are very common, but I'm still showing them. This is using a pair of forceps rather than anything, just to go all around the vitreous separation, all around the fovea first, and not go directly around it at the fovea. So the respecting the vitreofoveolar attachment, that is going around using forceps. The second one is this technique I like. I use a pick to, after staining, I use a pick to roll off the vitreous onto the fovea. That is not pull or push anything. A very gentle edge by edge rolling, like you do ILM peeling with a very you use a pick because it's a vitreous, it's not ILM. You just peel it off in segments. You just pull it off very gently across the fovea. So it kind of comes all off, and you can just gently roll off the stained vitreous off the fovea, and this is a pretty atraumatic technique. And that's it all. So this is the third technique, which the third technique kind of involves, sorry, I'll just show you the technique first and see. This is using a cutter. You take trypan blue and you do a proportional reflex, and you just put it underneath the vitreous and you pop the attachment off. So after that, the attachment comes off easily, and you can just, with the forceps, complete the rest of the surgery. That's it. Thank you.
When you said Ayurvedic, I thought you were going to have a head massage and then the PVD occurs or something like that. I was really looking forward to that, something like that.
Yes.
Yeah. One other thing is, like, in some of these cases, we can just put a gas and then see if it can, like at least the images you showed. So just inject a gas bubble and asking them to do the drinking bird position probably about like 3-4 times in a day, and many of them the PVD will happen, and then can try that as well.
Yeah, I'll just want to share one of my experience even after giving Ozudex also. This patient was having a VMT along with macular edema. So after giving Ozudex, so because of the mechanical movement, this VMT has gone away, and the other Ozudex has taken care of the macular edema, and the patient had a significant improvement.
Maybe you can try traumatic head massage and then PVD can happen.
Yes.
I think
some jerky movements can do it. So yeah, see, this is the idea of some innovative ideas. I'd like to thank all of you for this, putting up your showcases here. Can I just request all of us to have a quick photos, and we'll move on for the next session.